Okay, testing, testing. I'm gonna just test our sound out here, make sure everyone can hear us. Hello, hello, testing, testing. Gonna wait for some feedback here. Okay, excellent. Sounds like everyone can hear me and see Dr. Montgomery. So I'm gonna go ahead and get started. Welcome everyone to our first ever exclusive virtual quarterly education meeting for the Southeast Chapter SCCM. Thank you all so much for joining us during what we know are very difficult times, and really thank you all for everything that you are doing as critical care professionals right now. We appreciate you all so much. I want to start this meeting off as we always start our meetings, and that's with our mission and vision for the chapter. Our mission is to secure the highest quality care for critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. And our vision, all critically ill and injured patients in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. Just a couple of quick announcements. Our next quarterly meeting will be held on August 13th, featuring Aaron Cook, PharmD, who will be speaking on the topic of initial medical management of cerebral edema. Most likely, that meeting will be a virtual meeting as well, but look for more information via email or on social media soon about that. Information on how you can obtain CE for tonight's webinar will be emailed out after this meeting. So again, please check your inboxes for that. And without further ado, I'll go ahead and introduce tonight's speaker. Dr. Montgomery is an associate professor in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Kentucky, and also serves as the Associate Chief Medical Officer for Inpatient Services for UK Healthcare. Dr. Montgomery received her bachelor's degree from Transylvania University and graduated with distinction from the University of Kentucky College of Medicine. She then completed her residency in internal medicine and a fellowship in critical care medicine at the University of Kentucky. She is board certified in internal medicine and critical care medicine and a fellow of the Society of Critical Care Medicine. Dr. Montgomery's clinical interests include ICU care with a primary focus on long-term outcomes and ICU recovery. She's a founding member of the Society of Critical Care Medicine's ICU Clinic Collaborative. Dr. Montgomery is founder and director of the UK ICU Recovery Clinic and a national expert on post-intensive care syndrome. In 2018, Dr. Montgomery and her team won the Society of Critical Care Medicine's National ICU Hero Award for their dedication to the care of critically ill patients. Dr. Montgomery is involved in resident and fellow education and has been instrumental in the development of a resident curriculum within the medical ICU. Dr. Montgomery has had a lifelong dedication to the people of Kentucky and is passionate about continuing to advance the care provided by the university health system. So join me in welcoming tonight's speaker, Dr. Ashley Montgomery. Thank you so much.
Hello, can everybody hear me? Okay, can everyone see my screen? Virtual stuff is new for me, I apologize. I took typing in high school, all new, so. Okay, I'm here tonight to talk about what happens after the ICU and to discuss my experiences with post-intensive care syndrome as well as recovery of the ICU patient. So objectives tonight: detailing post-intensive care syndrome, identifying the risk factors, talk about ways to reduce it, and talk about how the ICU follow-up clinic plays a role in those objectives. I don't have anything that has influenced this talk at all. So I think we're all familiar with these pictures, right? I always talk about, here's the guy prone. This has become super common in my ICU with COVID right now. And then this picture, right? We consider this sort of the epitome of great ICU care. This lady's up in a chair on a vent, but as you can see, there's a lot of people, a lot of equipment, a lot of machinery over here to make this happen. And down here, this lady has a tracheostomy, a feeding tube, all of the things that we sort of consider standards for ICU care. But again, a lot of devices, a lot of invasive things happening to get just to a chair, right? And I think we take that for granted that in the ICU, the number of resources we use for these patients versus what they require after they leave the hospital are probably not that different. And yet we don't do a great job as a healthcare system of supplying those for the patients afterwards. So yeah, you survived. I just always like to remind people that there's about 6 million people admitted to the ICU every year, and about 5.5 of those will survive to discharge. And, you know, we all know that some of those patients are the alcoholic who comes in intoxicated and gets intubated and goes home the next day and probably doesn't have a lot of long-term sequelae. But of those 5.5 million, many of them are going to have long-term effects of their ICU stay, some of which are going to get readmitted to the ICU or a healthcare system of some kind, and some of which are going to have detrimental effects on their life, their quality of life forever. So as we have increased our survival rates, we've begun to realize that the percentage of people who survive an ICU stay and actually go back to their baseline is very small compared to those that experience some sort of PICS, which is post-intensive care syndrome, or PTSD, which is post-traumatic stress disorder, physical debility, or cognitive dysfunction, all of which can have big effects on a person's life if you think about sort of the global human that we all want to be every day. So I always just like to talk about this. So this is some data out of Dale Needham's study that was published in Critical Care Medicine in 2012, talking about what happens to people long term. So, and this was based on people who were intubated and sedated for 48 hours or more. So 50% of those people have ICU acquired weakness, 50% of them have some sort of cognitive dysfunction, and 30% of them have some sort of mental health or quality of life dysfunction, anxiety, PTSD, or sleep disorders. So I talk a lot about my patients because I think it's important in medicine to bring things back to a human being. I think sometimes we forget that the patients in the ICU are human beings because we kind of make them not look like human beings, right? So this is Daryl. He's a 51-year-old engineer. He's married. He has 2 kids. He had a congenital defect in the knee cartilage and had some knee pain his whole life. So he had one knee replaced a few years ago. It went really well. Went back to work, you know, within 6 or 8 weeks and recovered and was great. And so he came in to have his second knee done. He's a non-smoker. He's thin. He's an active hunter. And he decided to have the procedure done in late May because his wife is a school teacher, and then she could help with transportation and physical therapy and all those sorts of things. So he has his knee replaced. He gets in the PACU, he's extubated, and then he gets more and more hypoxic. He's placed on oxygen. They order a chest x-ray, and this is what comes back. At this point, we got a call from the OR saying something's very wrong. This guy looks horrible, and he got reintubated, right? He gets brought to the MICU. He has a central line placed, and we did a bronch, which showed blood everywhere, pretty traditional for diffuse alveolar hemorrhage. We stopped all his anticoagulation at that point, which for anybody who knows much about ortho and joint replacement knows that stopping anticoagulation is not really ideal in the ortho world. So over the next 24 hours, he got more hypoxic. He developed ARDS. He developed shock. He got steroids. He got paralytics. He got proned. And this was his chest CT. So not that different than what we're seeing right now, but this was a routine knee replacement, right? He didn't have a virus that we knew of. He didn't have anything. He came in for a knee replacement. Come to find out, I guess he had some sort of a reaction to sevoflurane, one of the gases the inhaled gases that are used for the anesthetic. But we didn't know that at this point. So he developed a ventilator-associated pneumonia. He developed a DVT. He had an IVC filter placed. He had a trach. He got a pneumothorax. He had a chest tube. He was in the ICU for 35 days for a routine knee replacement. On hospital day number 35, he was discharged to a long-term acute care hospital or an LTAC. A lot of the ICU patients go to these facilities. He was on 10 new medications. He couldn't sit. He couldn't walk. He couldn't talk. He didn't know what had happened at all, right? And then on day 63, so now we're at 2 months plus, he gets from the LTAC to the rehab hospital. He's on a bunch of new medicines. He can't feed, he can't walk, he can't go to the bathroom. He's seen 16 different providers. I think this is part of what a lot of people lose in ICU world, is that we think they see a lot of providers in the hospital when they're in the ICU, and we have all these consultants seeing them. You discharge them to another facility where a whole nother set of consultants sees them and changes the plan. And then you go to another facility where a whole nother set of consultants sees them. And at this point, Daryl has no memory of what's happened. And this is when he really started to complain to his wife about being anxious and depressed and wondering, what's my life going to be like? What's the next step, right? On hospital day 85, he gets discharged home. He's on 17 new medicines. And you notice that each time he goes to a new facility, they add more medicines, which I always find interesting because technically the patients are getting better. So why are we adding more medicines? But I promise they leave the ICU on fewer medicines than they get home when they go to these other facilities. He couldn't walk. He couldn't feed himself. He has no memory of anything that's happened. His short-term memory is really shot too. He's anxious, he's depressed, and he's having nightmares all the time and can't sleep. His wife is supposed to return to work in 12 days, and she's his primary caregiver. He can't walk. He can't feed himself. He can't go to the bathroom. She can't leave him. Wasn't ideal, right? But this is what we do to patients. This is what happens to a lot of our patients as they move through the healthcare systems and their families, because most of our patients are not operating independently within the healthcare system. They have some other people or person who is attached to them, who's helping them navigate it. Yay, you survived, right? So excited for Daryl. But now what? So as our mortality decreases and our survival comes up as a healthcare system, we have to figure out how to help these 5.5 or 5 million people who are surviving. And the majority of post-intensive care syndrome, the majority of ICU survivors have some substantial comorbidities that are moderate to severe in intensity. And we sort of collectively categorize and named these because we have to name everything, and then we have to give it a great acronym in medicine, right? PICS, or post-intensive care syndrome. Has to adversely affect your quality of life, has to adversely affect your ability to return to work, and fall into sort of 3 domains that we talk about: cognitive, mental health, and physical. So here's post-intensive care syndrome, and I'm sure that this is a graphic that a lot of people have seen. But I always put it on here to also talk about the fact that post-intensive care syndrome doesn't just affect the patient, but it also affects the family. So for the patient, the physical piece, you know, the shortness of breath, the neuromuscular weakness, the muscle fatigue and dyspnea, those sorts of things are the physical part. I think that's what most people think about when they talk about, oh, the patient was weak and, you know, debilitated after the ICU. But we also know that people have significant cognitive dysfunction, especially in areas of memory, attention, and executive function. And patients also have a lot of mental health issues: anxiety, depression, PTSD, and how to sort of separate those into categories can become difficult at times. But I always tell folks, you know, PTSD from an ICU stay, if you start to think about what we do to people in the ICU, right? I tie you down in a bed, I jab you with things indiscriminately without really talking to you about what I'm doing or you having any control or prediction about it. There's lots of beeping and noises and people talking that you don't understand. I give you mind-altering drugs. I cause pain indiscriminately, and I may or may not understand what's happening. I mean, it sounds like torture, right? And so the development of PTSD is very, very clearly on a similar path as many of the other things that cause PTSD. But we just don't talk about it much in the post-intensive care world, right? Or we didn't until recently. And the fact that these people wound up with a lot of anxiety and depression surrounding the fact that their life has been altered, they may not be able to return to work, their relationships with their family members are extremely strained, and then they've now got this PTSD-like syndrome that's making it very difficult for them to do basic things. If they could go to the grocery store, they're having trouble getting out of the front door and going because they're terrified. They're jumpy, they're emotionally labile, all those pieces that come along with that. And then there's a part of this that also feeds into the family, right? So in these patients, it's much like in the pediatric world in the sense that when they leave, they are not able to care for themselves and take care of their daily needs. Most of them can't meet their own ADLs. And so they're oftentimes very dependent upon family members to assist with this. Well, these family members are oftentimes at the bedside in the ICU and oftentimes also experience disruptions in sleep cycle, a lot of the unpredictableness, the fear, the anxiety, the constant, oh my gosh, what does that number mean? What's going to happen? The nurse came in the room. Is this good or is this bad? So all of those things just wind up feeding into a family member that may also develop a lot of mental health complications, right? and the fact that the family is stressed financially, stressed physically, stressed with time, and now they have this patient who's not like they were before. And the questions of, are you going to get back to normal? Are you going to come back to be able to go back to work and provide for the family? Or are you going to be able to take care of the children? Are you going to be able to even know who I am? Am I going to have to quit my job and take care of you? Who's going to pay for all this, right? All those pieces sort of feed into the PTSD from the family piece as well. So up to 50% of ICU patients experience symptoms in at least one domain. And we always talk about the risk factors for PICS. And this really only matters in the sense of sort of understanding what we might be able to do in the ICU to mitigate the effects, to decrease PICS. And it also plays into the role of, when I'm looking at a patient, how do I decide who's at high risk and what could I do maybe to help the family understand that before they leave? So we talk about ICU related factors, and this is really about how sick you are, right? So this is what could correlate, like your sofa, right? So were you on mechanical ventilation and how long? Did you develop delirium? Were you on ECMO? Did you have ARDS? Were you on shock? Did you have other organs that went down? Did you require renal replacement therapy? So sort of each one of those multiplies itself to create more of an environment where the patient is at higher risk for developing PICS. And then the patient-related factors, I mean, these are things that sort of in healthcare we would talk about as comorbidities, right? And none of these are shocking, right? If you are elderly, demented, have your fragility index or your frailty index is high, you have another organ system that doesn't work well at baseline, and thus you are probably somewhat unable to recover from a hit on something else, you're malnourished, or you have a previous mental health diagnosis that may be exacerbated. So these impairments can persist for months to years and sometimes never go away. And this is something that I always think is super interesting to look at. 85 to 95% of patients in the ICU have some sort of ICU acquired weakness, or 85 to 90% of the patients who have ICU acquired weakness, which we already talked about is at least 50% of the patients who are on mechanical ventilation for 2 days. At 2 years are still complaining of some of the symptoms, which is interesting, right? So at 2 years, they still don't feel like their physical body is back to being as strong as it was and they're able to do everything. And cognitive impairment. So I always talk about the fact that physical impairment, although visually more apparent to us, I think if you talk to families and patients, it's the cognitive impairment that really gets them. Because if the cognitive impairment wasn't there, they could be left alone. They could figure out how to use the wheelchair. They could figure out how to, cook on the stove, operate the TV. But with the cognitive impairment, they become unable to be left alone and tend to themselves, like almost like a child. And so it becomes a problem for families and patients moving forward. And then 33% of people who leave the ICU, their family members, when tested on standardized testing, have some symptom of PTSD, which is a pretty high number. Long-term PICS, we always think about sort of the immediate stuff, but long-term physical. So people complain of a lot of dysphagia for a long period of time and a lot of sort of abstract pain syndromes, talking about, and some of it is very specific, right? My wrist hurts where the art line was in as it's healing, and that may take months in a malnourished, acutely critically ill person. But some of it's even more vague. I've had chronic constipation since I left and I can't eat anything. My left leg just doesn't work the same. So a lot of that. And then in cognitive, the majority of the complaints around memory, planning, attention, sort of the higher level functioning behaviors. But you would be shocked how an inability to do one of those 3 areas can really affect somebody's long-term life. Mental health. So again, it's anxiety, depression, and PTSD. And how do you handle those? And as you all well know, many of these mental health disorders get treated with drugs that are sedating, which doesn't help the cognitive dysfunction nor the physical dysfunction, right? So it's a balance between all of that. So ICU acquired weakness, clinically detected weakness in critically ill patients, in whom there's no other etiology. We objectively evaluated in the clinic and in the ICU using the Medical Research Council Sum Score, the MRC-SS, right? 0 is complete paralysis, 60 is totally normal. Anything less than 48 is considered ICU acquired weakness. And this is a copy of sort of the way the test is scored. So you could see that to get a 3, you have active movement against gravity, but not against resistance, right? So 5 is full active. And so they test each of the different areas of the body, and that allows them to get a score. So 48 to 60 is considered normal, and 66 to 48 is mild quadroparesis, also ICU acquired weakness. We classically divided it into sort of 3 subcategories based on mostly on histology, so critical illness myopathy, polyneuropathy, and just general muscle atrophy. Myopathy is more proximal muscles, and this is people who have preserved sensation. So this is the people where you walk in and they can feel you, but they just really can't move very well. And when we biopsy them, the thick filaments are lost. And so with the polyneuropathy, this is more symmetric. It involves sort of everything. And this is the person who walks in and almost looks like they're paraplegic or quadriplegic in the bed. This is the person that they send to get the CT scan of their head. I don't understand why always, but they just look flaccid in the bed, right? And it's sensory and motor. And it's the histology when we biopsy them is axonal degeneration. And then muscle atrophy. So this is just general atrophy. It's symmetric, it's global. And usually has preserved sensation, and you just see sarcomere reduction in the fiber shortening in the muscles. One of the ways that you can differentiate between the different types of ICU acquired weakness is by EMG. So you can stick needles in the muscle and then look at, normal here versus neuropathy versus myopathy. So the question is the issue with the nerve muscle connection or with the actual muscle fibers themselves? It doesn't necessarily change what we do, but it is a diagnosis that helps us understand what's happening. And it's just a more detailed muscle filament. So ICU acquired weakness leads to profound limitations in functional status and increased resource utilization, right? And readmissions. You can imagine that if I can't feed myself, if I can't go to the bathroom, if I'm falling at home, all of those things, they really limit my ability to care for myself and my family's ability to take good care of me. People wind up with wounds and things of that nature. So ICU acquired weakness, so critically ill patient, things that we can and can't modify, right? So some things that we have actual evidence for benefit, glycemic control and shortening your time on mechanical ventilation. I'm not always sure how you do that, but things like the ABCDEF bundles and things of that nature that may help people get off the ventilator faster may help with ICU acquired weakness. And then we think that probably neuromuscular blocking agents and corticosteroids are not good, but maybe not quite as good of evidence. Early mobilization and sedation sparing protocols are good. Evidence is mixed, right? But I think we all think that moving and not keeping people drugged is probably good for them. And then theoretical benefit that's never really played out in any of the studies is optimizing nutrition and electrolyte management. So what can we do in the ICU? So get patients moving, optimize nutrition, and reduce sedation, right? And reducing sedation has to do with get patients moving. Letting people be human. I think in the ICU, we want patients to lay still in the bed because we're afraid they're going to pull out their line, pull out their tube, pull out their whatever. But the truth is, it's not normal for bodies to lay still and silent. It's not normal for brains not to have input and respond to it in an appropriate way. We just have to figure out how to do it in a way that's safe for both the staff and the providers and the patients. So delirium, another problem that we see a lot of in the ICU. It's an acute organic syndrome characterized by some of the following, right? And these things we see in lots of patients. And we oftentimes attribute it to drugs and other such things, but we all know that there's some patients who have the exact same amount of drugs as the patient next to them, and they both come out differently. One is very agitated, one is very lethargic and not moving, and the other person's like over on the ventilator writing messages on the dry erase board, right? So why are those 3 brains different? And we don't know exactly, but we know that the people who develop delirium have much poor outcomes than those that don't. So this is a picture that I always think is interesting and like to show folks. So this was done by one of the patients, and this is her memory of she was an artist and was really creative, but this was her memory of what it was like to be in the ICU, right? This is what she remembers. And it's always interesting to me to look like you can see the bed and the IV pole, which is there, right? And I don't know, I guess this is me or this is me. I'm not sure, one of these people. And that light that was over her head the whole time. And she talked about how this was always down here, the call button that the nurse was always like, don't forget to push your call button, right? And then I don't know what this gorilla is, but just sort of the chaos that your brain interprets from all of the varied and sundry inputs it's getting in the ICU while it's in a state of sort of semi-consciousness. And I always tell the residents when we round, equate it to the things that happen around you as you're waking up or going to sleep. And you have sort of weird memories of pieces and parts of it, but not the whole thing. And it almost gets incorporated into a dream-like sequence, but you know it's a dream. The problem with this is oftentimes patients don't understand what's real and what's not, right? And that part of it is very difficult. So why does it matter? Because each day a patient is delirious, it increases the risk of death by 10%. I mean, that's huge. 10%, right? That's a huge number. Increases long-term cognitive impairment, reduces functional status, and it increases hospital costs and length of stay. So not only is this a patient-centric metric, but it's also a hospital administrator-centric or specific metric. So these are things that affect the whole healthcare systems. And if there are things that we can do to help decrease these in our patients, then those are things we should be doing. So I think people think delirium is an ICU-related variable that's caused and not an effect, but there are things that we can do to modify it, right? I think there is some level of ICU psychosis or ICU delirium that's probably difficult, but there are things we can do to mediate it in many of our patients. So, old people, baseline comorbidities, and baseline cognition and severity of illness. These are probably not things I can change, right? And honestly, sepsis and hypoxemia, I may not have a lot of effect over, but maybe I could have a little bit. But things that I could have effect over, right? Metabolic disturbances, light, noise, sleep, trying to keep circadian rhythms in process, even if my patients are sedated, avoiding certain medications that we know can exacerbate it, right? Medications with anticholinergic effects, benzos, things of that nature, treating pain first. All of these things we know help patients with help reduce delirium in our patient populations. So treat pain, use a measurable, validated scoring system and treat it first, right? Trying to avoid benzos. And, it's been really interesting with all the COVID, many of our patients have had, I don't know, there was this whole theory that the patients were processing the propofol differently. And so we've been checking a lot more lipids on patients. And we went through a period of, I don't know, a month or so where everyone with COVID got sedated again on Versed. And we hadn't been using Versed in my organization as a primary sedation tool, except in our seizure population, or maybe some of the specific people who didn't tolerate propofol well for years, right? And so I had forgotten how hard it is to come up from Versed, how much delirium a Versed drip really does cause in a patient. And it's been interesting to watch as we've been going through this the last few weeks with the COVID, how returning to that really brought that to light for many of my residents. So the other thing is providing cognitive stimulation as people are coming up. It's not abnormal for someone who is tied down in a bed with a tube shoved in their throat to wake up and feel agitated. That is a normal response to that condition. So what we have to do at that point is provide them with stimulation that's appropriate. Having family involved, having music, interacting with them, sort of talking, hey, you're in the hospital, this is what's happening, mom's here. And again, COVID has also made this part really difficult, right? Because we haven't had as much family in the room to help with a lot of the things that they help with, especially during the sort of wake up period and the familiarity periods. Making sure patients have on their hearing aids and their glasses, even intubated. I go in the room and the patient's is on the vent and has their glasses on. That's a good day. Early mobilization, movement. Bodies are not meant to lay in beds, even on vents. Sit them up, get them in a chair, do whatever you can, right? Even passive motion just with arms and legs will help. Reducing extraneous noise. I think we all have become immune to it. It's just part of our working environment. But we go home and we all have times when there's silence around us, when it is quiet. And we don't really give that to ICU patients. There's always something chaotic happening around them. Allowing them to sleep. And even if it's not true sleep, even if it's some sort of a drug-induced comatose sort of state, allowing there to be dark and quiet times with minimal disruption from nursing staff and things like that really helps. Now, obviously, there's periods of acute critical illness when those things aren't possible, but it helps, I'm telling you. So using the intensive care delirium screening checklist, better known as the ICDSC, real catchy and short, right? So measuring all of these things and coming up with a score to help associate or to help define when patients are delirious, and then to create a system surrounding that that says, okay, if patients score highly, what are we going to do? We're going to talk about it on rounds, then we're going to decide what our next steps are going to be. So after the ICU, where do patients go? This is one of those things I think that people understand, but maybe don't really understand. So discharge destination is always going to be influenced by how sick you were, as well as what kind of insurance you have. And many of the ICU patients go to an LTAC or a long-term acute care center, but you have to have a medical needs. You have to have dialysis or trach or vent. You have to have wounds or IV antibiotics, and you have to have insurance. Big have to, right? And then there's the rehab hospital. So many patients go from the LTAC to the rehab hospital, or if they stay in the acute care setting in the hospital for long enough, they might just go right to the rehab hospital. But you have to be able to participate in 4 to 5 hours of physical activity. You got to have insurance, and you can't oftentimes be delirious, right? So where else? So the SNF or the skilled nursing facility. So you have to have a payment, and that gets real weird, like how many days you could have for subacute rehab there versus are you living there? You can't have a trach, you can't have a drop-off tube, you can't have profound weakness, and you can't have behavioral issues. So you could just stay in the hospital, right? We'll take care of you there, but we don't really have great PT, OT scheduled services. We have great PT and OT people, but they only see patients every 3 days. It's not an everyday 4 hours a day kind of situation like the rehab hospital. I don't have a swimming pool I can go put people in, right? Those are things. Or then there's my favorite, which is home with assist, right? Who's doing this assisting? This is the family who's doing the assisting. The family who has little to no healthcare training, most likely, and is being asked to provide medical or physical care for their loved one. And then there's always the hospice, which has lots of resources, but you have to qualify, and you have to be willing to say, or at the point in your life when you say, I'm actually dying and would like to go to hospice. So those are sort of the destination options. And there's very little communication between these different facilities, right? So you move from the ICU to the LTAC and you send a discharge summary and some notes. And I don't know how many of you have actually looked at the notes that we send to those facilities or what is done with them and what actually gets inputted into the next phase of care, but it's minimal, right? They get a new doctor who decides what the protocol is at their facility. They consult a different cardiologist than the one they saw with us, a different ID doctor, a different renal doctor. And sometimes occasionally you get lucky and there's a little bit of like maybe the LTAC's in your hospital and so you're using some of the same people. But then they go on to the acute care hospital where they have a different set of physicians and a different set of providers and a different set of consultants. And we're talking about patients who can't even really tell you what's happening on a daily basis, more or less what was told to them by the previous provider. And families are completely overwhelmed, right? They've been living in an ICU for months and aren't doing very well at baseline. And now we're asking them to be the communicators of all of this information from one facility to another. I mean, how many times has the family shown up and you say, so what did they tell you at the other hospital? I mean, really, do you think that family understood or really put that in a box and said, oh, I need to take that to the next doctor? No, they were completely overwhelmed. And so after many days in the ICU, they often are just sort of lost souls functioning next to these poor patients. So this is patient number 2, David. He's a non-smoker. He's BMI is 20. He's an ultra marathon runner. So he ran like crazy, like 50 and 60 mile kind of things. He had a splenectomy at age 14 after he fell out of a tree. And he went running one day and got bitten by a dog. A couple days later, the bite looked bad. He had some fever and fatigue, and he came to the ED at our hospital, and he waited for 3 hours to be seen. He got frustrated and said, forget it, I'll just see my primary care doctor, and he went home. Went to bed with his wife, and she found him non-responsive the next morning in the bed. This is what he looked like when he got here. He was real bad. He had septic shock requiring pressors. He had an AKI, went on renal replacement therapy. His pH was 6.9 when he got here. He's one of the few people I've seen with pHs in that range who weren't diabetic ketoacidosis who survived. So he had a CT head that showed diffuse edema, labs consistent with DIC, and an echo that showed his EF was down to 20 to 30. He had run 12 miles 72 hours earlier. So this was pretty acute for him. His blood cultures grew capnocytophagia, which is a common oral flora of dogs and is especially virulent in the asplenic population. But I guess David, as educated as he was, no one had ever talked to him about how he had special risks with his spleen out and should be treated differently, right? He got a feeding tube. He had a dialysis catheter, an art line, a central line. His feet and toes turned black. He developed pretty bad cardiogenic shock from this and meningitis. and spent 12 days on mechanical ventilation. He went to an LTAC on day 26. He was told he was probably going to lose his feet, and he couldn't hear. We had a lot of trouble extubating him with delirium. And come to find out after all of this, it was because he couldn't hear anything. And we were asking him to do stuff, and he did not know what we were saying. And he was too delirious to really be able to understand and communicate that he couldn't hear or to read our lips or do those sorts of things. So for day 48, he gets discharged to a rehab hospital, lots of new medicines, has a tunnel dialysis line in his chest. He's tired. He's seen 14 physicians. He and his wife are overwhelmed. So here he's on the track again, right? ICU, LTAC, rehab hospital, and home. A lot of these ICU patients arrive home debilitated and cognitively impaired. So it's not that these debilities and cognitive impairments affect their recovery in the LTAC and the rehab hospital, which they do. But then once they get home, they have all of these debilities that are new, and the family and the patient don't know how to handle. So they can't read or write. They can't follow simple tasks, right? I have so many patients who come and with their families, and the families say, I write down directions for them every day, and they can't follow them. They can't bathe themselves, dress, walk, feed. They're on oxygen. And then the patients are very easily frustrated. They have a lot of emotional lability, a lot of PTSD. They're very fearful, and they can't sleep. Not being able to sleep is a big complaint. So ICU patients have complex needs, lots of organ systems that are down, and lots of different things that need to be addressed during different stages of recovery, right? So medications, physical, cognitive rehab, driving issues, returning to work, all the relationships and the strained finances and social context that occur after this. And I don't know how many of you all have been in a PCP practice, and I have lots of friends who are PCPs, so I don't want anybody to think that I am in any way criticizing them, but the current model of primary care in America is not set up to deal with this, right? It's come in, tell me your problem, we'll address it and move on, and then once a year you come see me for your sort of big health annual exam where I am with you for a little bit longer and ask some more detailed questions. But you can imagine that this patient showing up for their post-hospital discharge 20-minute visit, it is going to be challenging. And the communication between the intensivists and the PCPs is poor, right? Since running the ICU clinic, kind of make it my motto. When I have people in the ICU, I pick up a phone and call the doctors, the PCPs, which you would be shocked at how appreciative the outside physicians are for just verbal communication from a doctor, right? And they oftentimes know things about these patients, especially in rural communities. They may have seen them in their family for many years. And when they get home, often these patients have seen 10 different providers during their illness, have lots of new medicines, and they don't know what's important and what's not, right? Which of these consultants that I have from all these different places do I actually need to see? Which of these medicines do I need to take? Are any of them duplicates? How do I know? I have this bag from this hospital, and then they sent me home with these scripts. Who's going to explain all of this to me? And I can't get in to see my PCP for 2 weeks, and my PCP is giving me a 20-minute appointment, right? And I always talk about, if you have an MI, you see cardiology. If you have a stroke, you follow up with neurology. If you have renal failure, you follow up with nephrology, all of this. But if you go to the MICU, you get all of this, right? With no central ringleader, no person helping guide the patient through the complexities. So ICU follow-up clinics sort of originated from this thought that patients and families needed help navigating the healthcare system and recovering. And that if we were going to spend all this time and resources on them in the ICU, we should probably help them navigate the next step and become functional members of society again. And that this concept arose because the thought was someone familiar with what had happened to the patient in the ICU might be able to better help them navigate that system. So the first ICU clinics were established in the United Kingdom, and this says 20 years ago, but it's probably now more than 30. And interestingly enough, so they have a whole network there, and everybody who goes to an ICU in the United Kingdom gets referred to the ICU clinic that's in sort of their region. So you may not see the doctor or nurse that saw you in the hospital, but they have a clinic specially set up that's close to your house, close to wherever you live, your hometown, and you go and you see them. They're all run by nurses, and they're done beautifully. And they follow the patients for 6 months to a year after they leave the hospital. And it's just sort of a mandatory thing that happens. The first U.S. clinic was established at Indiana School of Medicine in 2011 and focuses initially on the geriatric patient population. And it's called the Critical Care Recovery Clinic. And the second clinic was established at Vandy in 2012 and was called the PICS Clinic. And The model for these clinics is mostly transdisciplinary. So we recognize that it's not really just about a physician. It's about a group of people helping shape the patient's recovery, right? So we have a physical therapist and an LCSW, and oftentimes the patients are coming as much to see those people as they are to see me, depending on sort of where they are in their trajectory of recovery. There's really not a standard of care or ideal model, although most people would say that the goals of the clinic are to improve the quality of life of the patients, to decrease the readmissions, to decrease healthcare resource utilization. The University of Kentucky Clinic here was established in 2013. We have clinic every week for a little more than a half day. We have a physician, a pharmacist, a nurse, an MSW, and a physical therapist that are all specifically dedicated to the clinic and have a specific passion or interest in ICU recovery. So this is sort of the schedule that we follow here at the University of Kentucky. And we meet the patients and the families in the hospital. So we scan what we call our DCR every day and sort of look at who's in the hospital and who might be appropriate. And then the nurse practitioner from the clinic goes and she introduces herself to the family. We have some brochures that we take to them talking about PICS and post-ICU care, just sort of familiarizing the family and the patient with what to expect. And then we schedule them an appointment, sort of trying to predict when they will return home. And we try to see them that first week they return home. So if you get discharged from the LTAC, we want to see you within 5 days. Because we find that that's when people really begin to notice the issues that they don't know how to take care of, right? This is when the things come up of, oh, we had that bed that went up and down and our bed doesn't go up and down and I'm really having trouble getting you out of the bed. Or we don't know which of these medicines we're supposed to take. And so we schedule that initial appointment. And then we see people 1 month later, 3 months, 6 months, 9 months, and 12 months. So in the initial appointment, it's ideally the first week the patient returns home. We say it's 60 minutes. It's really more like 90. We do a complete medication management reconciliation with our pharmacist who looks at what they were discharged on, what their home meds were before they ever came to the ICU, what their chronic conditions are. She talks to them a lot about supplements and things they could be taking that might be interacting. And then she brings that information out to the team. We go through all the referrals that they've had from outside physicians and providers. And then we talk about issues within sort of the PIC. So the PT sees them and does an assessment. We have a registered dietitian and MSW, and they all go in and sort of do very standardized assessments and talk to the patients and the family about, well, here's what your scores show. Here's where we think you are. We want you to know this is normal. This is what happens after the ICU. What are your concerns? And then we do cognitive PTSD and mental health screenings as well. We do a lot of family support, sort of talking about what are you struggling with, what do we need, and helping them get resources that they might need. And then on that first visit, we tend to do some basic labs and some basic imaging, just to sort of see where we are. And then at our 1 month appointment, we do spirometry and some more labs. And then this is usually where we start talking about pulmonary rehab referrals, PT referrals, and really working on specific things related to ICU recovery, right? So oftentimes we discovered through this process that just things as simple as, so somebody comes in and they're 45 years old and they come to the ICU Recovery Clinic and they're using a walker, right? They didn't use a walker before they came to clinic or before they got sick. They're 45 years old. And they say, yay, I've been discharged from physical therapy. And we're like, what? You're on a walker. How do you get discharged from physical therapy? Like, you obviously still need balance training and all kinds of stuff. But we found that a lot of the people out in rural Kentucky, and no fault of their own, the PTs, the OTs, the speeches, all those people, they just weren't familiar with what the patient population needed. And so they were like, well, you've made great strides, and they would discharge them. So we did a lot of re-education down there and have sort of set up a network in the rural communities now where we can call and be like, hey, I'm going to refer you to Hank. Hank's really good at ICU recovery stuff, and he'll help work you through it. We also do a lot of cardiopulmonary rehab referrals because we found that just getting out of the house and going to pulmonary rehab and having some supervised exercise really makes a difference in people's quality of life and depression. But it also gives them sort of a safe environment to push themselves and say, it's okay. We also do a lot of counseling, repeating things from the first visits, making sure that we're walking through the patient's sort of care continuum, right? If you had an IVC filter placed, how are we going to decide when to take that out? If you're on anticoagulation, how long do you need to be on that? If you got started on a beta blocker for AFib, how long does that continue? Are you having trouble sleeping? What can we talk about that might help with that? What do you need at home that you don't have? All those sorts of things. talk a lot about vaccines and preventative medicine moving forward and making sure that people haven't missed sort of traditional annual screenings. And we find that oftentimes during this period, we become almost like a primary care doctor to these people, primary care doctor on steroids. But just because their primary care doctors are so overwhelmed with their ICU care and what's happening, that the patients sort of defer to us. So we do lots of phone conversations too with primary care doctors. Hey, could Sally come back to you and get her echo? I don't think that she needs to be on a beta blocker for AFib forever. So can we just make sure that her EF looks good and she's not having any arrhythmias? And then you call me and we'll talk about what we're going to do next steps if you feel uncomfortable, right? But then Sally doesn't have to drive 100 miles to me to get an echo that she could get in her hometown. So this is who we currently invite. Anybody mechanically ventilated greater than 48 hours, new trachs, shock requiring pressors, organ failure, anybody who has diagnosed ICU acquired weakness, ARDS, anybody on ECMO at our facility gets referred, anybody with delirium. And we tend to take the very old and the very young. The very young because they don't typically have a good social support network to help care for them. And it's very overwhelming, right? They're not used to having to take medicines and go to doctors and do all these other things. And they're very old because they're oftentimes overwhelmed and their social support structures are overwhelmed. And so just helping them sort of manage through all of those pieces. So this is the referral. This is the way to refer to us. We have our own email and it's published on our website. So patients can find it from outside and outside physicians can find it. And we do a lot of collaboration with the PCP, as I said. So we do a lot of phone calls, but we also provide patients when they come with a sample, a paper that sort of simplifies their ICU stay. What happened to me? What procedures did I have? Do I need to tell anybody about these things? And we always try to include things like, if you have renal failure, you should mention this to any radiologist, your primary care doctor, anybody prescribing medicines to you to make sure they understand how that might play into it. And some of it for some patients is too simple, but for many of our patients, they're very grateful. And they can then take those forms back to their primary care doctor or back to all their different consultants and say, hey, do you all know exactly here's the things that the ICU Recovery Clinic thinks it's important that you know. And then we also try to set up people who don't have primary care doctors with primary care doctors that we know are familiar with PICS and post-ICU care in their rural communities. So how does this help the system? So it offers immediate support for medical needs. It helps avoid ED admissions. And we try to avoid referrals to specialists, right? I'm trying to help the primary care doctors in the hometowns not refer the patient to yet another specialist, yet another cardiologist, yet another GI doctor who doesn't even know what happened to them in the hospital, right? And maybe that long-term, that's going to be the easier place for them to go. And oftentimes the patients and I will talk about, you don't need 2 GI doctors, right? You either need to see the person at UK or you need to see the person in your hometown. But having too many doctors confuses everybody, especially you. So we oftentimes do a lot of conversations around which consultants do you need to see. So how does it help the system? So this is some data out of Geisinger, which are some colleagues of mine that participated in the ICU Collaborative. And I always like this data because I think it shows what we could do in the best of situations. So Geisinger is a closed health system. For those of you all that aren't familiar with it, it exists in Pennsylvania. And it's, if you buy Geisinger insurance, then you go to Geisinger doctors, Geisinger hospitals, and you abide by the Geisinger health plan rules, right? So it's a major HMO sort of a situation. But so at Geisinger, what they did was they went to every single patient in the ICU and they referred them all to the ICU clinic. And then they looked at readmissions and length of stay for people who were in the ICU clinic cohort or who got usual care. And usual care was just, they didn't show up to clinic, right? So you could argue, obviously, that the people who didn't show up to clinic either were sick and couldn't come or didn't have great behaviors to begin with. And that all may be true, right? But in general, this is as about as good a data as we're going to get on the readmission rates from specific ICU recovery clinics at this point in time. And if you look at the 30-day readmission rate for people who came to clinic, it was 6.7, and for those who didn't, it was 16.8. I mean, that's a huge number. That's a huge benefit, right? And at 60 days, they're still seeing very significant benefits. So this is not only good for the patients, but good for the healthcare system, right? If I can prevent that many readmissions by allowing somebody to come to a clinic that helps them re-equilibrate back to a more functional life, that's very, very good for everybody. So Family support's also one of the things we talk a lot about. Families are just exhausted and financially depleted, and they need lots of counseling on the details of what they can and can't do, what the expectations should be, what the timelines are going to be, when can people go back to work or not, all of those things. And I always say, think about if tonight you went to bed and you woke up in the morning and your entire life had to go on hold, right, for the next 30 or 60 days so that you could support somebody in your family. Can't go to work, can't go to school, can't do anything. Like, how are you going to make that happen, right? It's very challenging. So after the ICU, so Daryl showed up to clinic for his first appointment in a wheelchair. He was anxious. He was very short of breath. He went to pulmonary rehab. He did lots of counseling. And it was very obvious from the beginning that Daryl had some neurocognitive dysfunction that was not present prior to his ICU stay. He did actually go back to work, but he had such anxiety that he was going to mess up because he knew his brain wasn't working correctly, that he would find himself sort of avoiding colleagues, not going to meetings and not doing things. And we finally decided that returning to his previous work as an engineer just wasn't going to be okay for him. He still struggles with memory issues and an inability to do things that he physically used to do and be easy, but he got a therapy dog, and his dog has really brought him a lot of joy. He really got active in the SCCM and the Surviving Sepsis campaign, and has sort of traveled the world talking about what it's like to be an ICU survivor, what it feels like to be in the ICU, things that can benefit ICU patients. And it sort of made it his life's mission. And he also volunteers at our hospital, not during COVID, obviously, but on normal days, if those ever return again. As a family sort of support person, he goes up to the ICU and goes in patients' rooms and sort of just talks to families about what it's like to go to an LTAC, what it's like to go to rehab, what it's like to have a tracheostomy, what might be the long-term effects of these things, and that he's not the same as he used to be, but that it's okay. He would tell you he's better. So these are some pictures of Daryl. So he's an avid hunter. So this is a turkey that he killed and he wanted me to see. And this, he told me he was going to stand on his head. So he sent me a picture of him standing on his head. David came to the clinic in a wheelchair and he was emaciated. I mean, he wasn't a big guy to begin with because he was an ultra marathoner, but he was emaciated. I think his BMI was like 17 or 16.5 or something when he showed up. He was frustrated and he was deaf and he had to write everything down. He couldn't hear anything. It was very frustrating. He couldn't talk on the phone. He couldn't communicate. He couldn't watch TV. It was awful. So we referred him to ENT and he got a cochlear implant in place. His kidneys recovered and he was actually able to go back to work with cochlear implant. He was able to hear what was happening around him. He had to have several surgical amputations on his feet, which was actually David's biggest complaint. Like, the ears frustrated him, but his biggest thing was, I want to be able to run again. And they told him originally he wouldn't be able to run. And I was like, yeah, let's not count that out quite yet. So he had a bunch of amputations and his feet don't look normal outside of his shoes, but he's able to put on shoes and run. And 12 months later, he ran his first 10K. So I thought that was pretty good. And there's David and his wife and me and one of the other physicians who was in the clinic. So they were very grateful. So I always like to just give a little shout out to the Society of Critical Care Medicine and the Thrive Initiative, because I think through them and the development of the ICU Clinic Collaborative, there was a lot of collaboration going on around the country. The University of Kentucky was one of the first 8 participating sites. These are some of the goals of the collaborative, and we came together once a month and sort of just discussed how to better care for this patient population in a group that was full of people who are equally dedicated to taking care of patients long term. And I think that will be something that I will forever be grateful for, just in having a community to help develop care and understanding what the variables were and how to navigate administrators and things of that nature became very, very beneficial. So thank you. Questions? Now we're going to test me and see if I know how to actually use this.
Are you able to hear me?
I can.
Excellent. Thank you so much. It was a wonderful, wonderful talk. There's a lot of engagement on Twitter going on as well. So check that out for sure. I'm not seeing any chat questions. Are you able to see any from the chat?
Nope. I don't
If
see
anyone
anything.
has any
I don't see
questions, please
chat.
feel free to type them in. Let's see. Someone saying they did send one.
For hospitals that don't have a PICS clinic or resources, what do you recommend for patients? So one of the things that I think is most important and that the patients talk about a lot is normalizing the PICS experience, right? Telling them while they're still in the ICU, while they feel delirious and confused and that their brains aren't working correctly, to talk to patients and families about the fact that that's normal. To say nobody expects it. Your brain is as sick as the rest of your body, and no one expects you to get up and walk across this room or be able to breathe independently. So we also don't expect your brain to return to normal. It's normal. And to tell the families that it's normal, but that it may not be permanent. I try to set expectations early in the course, like, they may come off the vent, they may not. They may come off dialysis, they may not. Their brain may recover, it may not. But to sort of paint a picture of the fact that a lot of what they're experiencing, we talk to patients in detail about vents and renal replacement therapy, right? And what medicine to take for their AFib, but we don't really talk about all the other pieces and parts of it. And so I think it starts with that. Then the other thing, making sure your staff is educated on it too. I think sometimes that's part of where people struggle. So residents, fellows, nurses, all of those people who come in contact with the patients, really making sure they understand and normalize the process. The bedside nurse is with the patient a lot more than the providers are. So having them understand what's happening and be able to communicate that to the families is just monumental and can be exponentially beneficial to everybody, in the sense that if they're talking to the families and patients about those things from the beginning, then when it happens, it doesn't feel so abnormal. It doesn't feel like it's the world is ending. And then I try to direct people to the SCCM website has some great resources on there for what is PICS. They have a whole sort of video on it that people can watch. And they actually have some resources that they can link you to. So cognitive games that you can do to help cognition in different areas, physical exercises that can help, all of those sorts of things. And there's sort of a nationwide network of PICS clinics. And if you don't have one in your area and you could find one to refer people to, most of us take referrals from all over. And even if patients only come once or twice, right? I have some patients who've come from outside facilities. We didn't see them here, but they came because they were like, oh my gosh, I got home and I didn't know what to do, and nobody else did either. And so they come to see us a couple of times and just sort of build that relationship and help structure all of that and then move on. So that would be what I would say. And again, education and familiarizing the people who come in contact with the patients is probably, it goes a long way. I'm not going to lie.
Yeah, for sure. We have another question. What is your biggest word of advice on starting a PICS clinic in your healthcare facility?
My biggest word of advice: don't be discouraged. I think people underestimate the amount of resources that these patients need. And so it took me a long time to sort of pull together people who were equally as passionate about it, right? And it's sort of like, I think you can't take somebody who really loves pathology and being in a microscope and doing those sorts of things, and then put them at the bedside and expect them to want to go have a 20-minute conversation with a family about death and dying, any more than you can do the reverse, right? I would feel trapped and horrible if I was in a radiologist suite all day in the dark, but the radiologists love it. So you have to find people to work in these situations who are passionate about it, who enjoy the work and who want to help this patient population, right? And then finding those people and bringing them together was part of my struggle for a long time. And now that I found that group, I'll probably never let them go. But I think finding them, bringing them together, and then being patient with building figuring out how it works in your health system, right? Because everybody's health system operates slightly differently, and trying to take my model and make it work at your health system may not be what's best for your situation. Trying to figure out which patients are really falling through the cracks and how can I access them and how can I get them here and how can I support them and what supports do they need. And there's lots of different models for that. So sort of being open to non-traditional ways of helping people would be the thing that I would say too.
Excellent. And to tag on to that too, of course, as a dietitian myself, I absolutely loved hearing that you guys have a dietitian in your clinic. I think that's probably the first that I've heard. And I have a question, and I'm curious to know how many of the patients you see in the clinic are coming back with feeding tubes. And are they often tubes that have maybe gotten lost in the mix that need to be taken out? Are they still using tubes? Obviously, like you mentioned, dysphagia is a long-term complication, but I'm curious about the feeding tube situation in this scenario.
So you mean like a peg tube or like a DAPA?
Yes, like a peg tube.
So you know how many patients come back with them. So I will say more people come back with feeding tubes than trachs, which I find interesting. And I think part of that's because the ability to breathe on your own, I think, recovers in a more visual way. Like people are walking around doing stuff and they're at the LTAC or the rehab facility. And they're like, oh, you don't need that trach anymore, right? But then people have this sort of idea of, oh, that feeding tube's not bothering you. We'll just leave it in case you need it to supplement, right? And then people supplement and then they don't eat. And there's this whole other thing that goes on with that. But
Right.
the surgeons, a lot of times people will refer people to a random surgeon to have their peg tube removed. And so oftentimes they come back to us in clinic and are shocked when we're like, well, do you just want us to take that out? Are you using it? Right. And they're like, no, can you just do that here in clinic? And we're like, yeah,
Right.
it's not hard. You just pull and it comes out. Right.
Yeah.
And so I think part of that process just involves the communication. Peg tubes tend to get lost as well in our facility. Like I do all the trachs, I do all the other procedures, but I don't do the peg tubes. Right. And so a lot of people sort of consult a surgeon to come and do a peg tube, or if the patient's obese, they may have to go to the operating room or something. And then they don't really get scheduled to follow up with the surgeon. Right. And so if the ICU patient doesn't come back to see me in clinic, who's taking out their peg tube?
Yeah,
You'd be
exactly.
shocked how many people still have them for a long time. And
Yep.
dysphagia is real, right? It absolutely is real. But there aren't a huge number of patients who at 6 months or a year can't eat by mouth in some way, shape, or form.
Right. Yeah.
Most of them can have a modified diet, can do modifications, can work with speech therapists and things on their dysphagia and improve their situation dramatically.
Yes.
But we do a lot of removal of peg tubes on visit
Good to
numbers.
hear. It's very good to hear. Yeah. Excellent. Let's see. I don't think I see any more questions. Do you have any more on your end?
I don't think so.
Awesome. Well, thank you so much. This was an awesome talk. I've already gotten some great feedback from some folks saying that they've really enjoyed it. We really appreciate you taking the time and look forward to hearing more from you on Twitter and elsewhere. Thank you so much.
Thank you. Bye.
Bye-bye.